Welcome to everyone, and thank you so much for attending. My name is Vicki Ellingrod. I am the Senior Associate Dean in the College of Pharmacy, as well as the faculty chair for the education group within Precision Health. Today is the fourth webinar of our educational series that's designed to connect clinicians and healthcare professionals with concepts that are key to understanding the role of learning health sciences, artificial intelligence, and machine learning in clinical care. The title of our entire series is called Demystifying the Data, Processes, and Tools that are Changing Clinical Care. It was originally developed in collaboration with Dr. Cornelius James from Michigan Medicine, as well as significant input from our Precision Health Education Workgroup members. This webinar series is going to culminate in a symposium that will be taking place on March 16, something that we are very excited about. This will be an in-person as well as have an option for remote participation, so please save that date. We also invite you to mark your calendar for another great webinar next month. This event is called How Clinicians Can Access and Benefit the Precision Health Tools, and it will take place on February 10th at 12:30 p.m. My dogs are about to bark, just letting everyone know. This will be a nitty-gritty description of how to access tools with real-life examples of how your colleagues have, used precision health data. Before we begin today, though, I'd like to provide you with information about precision health if you're not familiar. We are focused on improving and advancing discovery, treatment, and health. And with those objectives in mind, over the last 3 years, we have built new and innovative infrastructure that supports interdisciplinary research across the entire Michigan campus. If this is something that interests you, I highly recommend that you become familiar with our analytics platform, which was developed to help researchers from all disciplines and all levels gain access and to use precision health data. We also have unique data sets that can enrich many research projects focusing on precision health or other health issues. Yet, we also know that research that doesn't make its way into the clinic cannot improve health. So Precision Health realizes the importance of translating its findings into practice. Our implementation work group has been doing just that with recent research findings on such health issues such as C. difficile infections, overall mental health, as well as COVID. In addition, each year we provide the U of M community and others opportunities to learn more about precision health through webinars such as this one, our symposium such as the one coming up in March, and more recently our first in the nation Precision Health Certificate Program, which is open to graduate and professional students across the entire U of M campus. You can find more information about everything Precision Health has to offer, other programming that we have planned, and other tools, as all of this is available on our website. We also invite you to become a member. We have almost 250 members now, and every member is able to use our resources, receive effective communication to support and publicize their work, and enjoy other benefits. Now on for today's event. Today, we are going to be covering very important territory, areas that we don't often hear very much about. The topic for today is ethical and legal considerations for precision health research that incorporates machine learning and artificial intelligence to improve care. Our format is going to be refreshingly informal, as our speakers are not going to be using slides, but instead will be having a dialogue amongst themselves. We would like you to participate as well, and there will be a specific question and answer session at the end. So if you use the Q&A box that's on the bottom of your Zoom screen, you can submit your questions at any time, and I will make sure that we cover those questions at the end. Today, we're honored to welcome two experts who are here to share their knowledge on this important aspect of precision health research. We have Abigail Jacobs, who's an assistant professor of complex systems and information at the U of M School of Information and of Liberal Arts and Science. She's a computational social scientist whose research interests are around structure, governance, and inequality in socio-technical systems, measurements, and social networks. She is joined by Nicholson Price, who is a professor of law at Michigan Law. He teaches and writes in the area of intellectual property, health law, and regulation, particularly focusing on law surrounding innovation and the life sciences. So with that, I want to thank you both for being here today and for participating in this really important webinar. I am now going to mute myself, mute my video, and let you both take it away. Again, for our audience, if you have questions, please put them in the Q&A and I will make sure that they get answered. Thank you.
Thank you for that introduction. So just for a little bit more background on each of us, I'm Abigail Jacobs, an assistant professor of information complex systems. My PhD is in computer science, but I really have an interdisciplinary background and interest in that interdisciplinary work. Here I'm affiliated with the Data Science Institute as well as the Center for Ethics in Society and Computing. I've worked in machine learning, but I really like thinking about sort of the social impacts and what gets implemented in our computational systems. So in that work, I work with social scientists. I spent a few years at Berkeley working with insurance and prescription claims. So really sort of covering a bunch of different domains where computational systems are making decisions and we get to think about the kinds of design and implications. Nicholson.
Hi, yeah, I'm Nicholson. I teach the law school, and I'm really interested in kind of the way that the law interacts with new biomedical innovation, largely how the law shapes that development, but also what those developments mean for law. And I'll be talking about some of each of those things today. My background is in both law and biology. I did my graduate work on protein crystallography and medium scale data mining, so I have a little bit of experience when data sets get big-ish, but not genuinely big of the kind we'll be talking about most of the time today. And I tend to think about things from the 10 to 15,000 foot level, that kind of space. Oh, I should also say 2 disclaimers. Don't judge us on the medicine. Neither one of us is a medical doctor. So if we say something and you're like, oh, that's not how you should treat sepsis, please don't discount all the other things we say. 2, I'm a law professor, but I'm not a lawyer, and I'm definitely not your lawyer. So please don't treat anything I say as legal advice. It's not. With that, I'll turn it back to Abby.
All right, thank you for the disclaimers from the legal scholar. And so I just want to give a quick background on what we're thinking about when we talk about AI, artificial intelligence, machine learning, terms that get used pretty broadly, pretty loosely, often get treated like magic, but I would argue should not be treated as such. But we're interested in the kinds of systems that typically are learn from or trained on data sets, which is to say we can build systems that look at what patterns have happened in the past to say, this is what we might want to predict who needs some service the most, or what a good summary of this text would be, or maybe what this patient needs, whether that's sort of at the bedside or in terms of enrollment at for a treatment regime. But So this means we're somehow working with data in these systems that are somewhere behind the scenes, somewhere in the systems that you're working with. But I guess I just really want to underscore that these are really, this is a term we'll use loosely. And I think to meaningfully think about AI systems, you really need a multidisciplinary perspective. As we'll talk about some today, there's a lot of social, cultural, political, medical things that go into the making of these algorithms and how they get used and where they show up and how you interact with them. So you really need to be able to integrate a bunch of different perspectives. And so a running theme will be that we're sort of not just talking about the technical aspects, and really that you need this kind of broader context in order to think about the impact of these systems. So just for some structure for today, I think it's easiest to think about AI or machine learning in a specific setting. So we're going to spend a little bit of time with a focused example on thinking about a sepsis prediction setting as sort of just a place to illustrate what kinds of issues are going on upstream in the creation of these systems, what happens when they're implemented, what happens at bedside or at clinical decision-making time. And so we'll take you through that process. And partly we'll take you through that process because even if you don't interact with those who are designing these systems, if you're not designing sort of what inputs go into these systems, or even which systems your healthcare system acquires, these systems influence you. You have to interact with them. You have to make decisions about what they are and are not doing. And I think the lesson that we most want to emphasize is that, yes, some of these tools will be increasing in their accuracy and prediction rates, and they'll be getting increasingly better as time goes on. However, the problems that are here are not because these systems aren't sufficiently advanced. We're not just waiting for the next update that makes these systems finally work the way we want them to. That will help, but most of these problems aren't going to go away. And so we really need to be able to reason about the systems that we're interacting with. And so what we're hoping today is sort of bring you all on board to be able to reason about these systems sort of throughout their pipeline. At the end, we'll have time for questions. But for now, Nicholson, do you want to tell us about sepsis?
I would love to tell us all about that. Thanks so much, Abby. What a terrific handoff. So I'm guessing that most of the people in the room have a good sense of sepsis, and in fact, probably a better sense than we do of what sepsis is, but maybe not so much about machine learning for predicting sepsis, right? So just as a background, if you happen not to, sepsis is an extreme reaction to infection. It's a big deal. Shockingly high mortality rate in the high 20s for patients diagnosed with sepsis. It's the single greatest inpatient cost to Medicare. It's expensive. It's tough to deal with. Lots of people die. But if you intervene earlier, outcomes get much better, right? We can predict sepsis and enable earlier intervention through things like antibiotics and IVs and vasopressors, et cetera. And so the idea here is that this is a space where it's really useful to be able to predict sepsis as early as possible so that interventions can be more effective and placed at where they're most needed. And it's also the kind of thing that machine learning and artificial intelligence is pretty good at. There's lots and lots of data in patient records about patients who got sepsis and patients who didn't get sepsis, and the course of their treatment and all of their indicators and their vital signs and all of this information. And that's the kind of stuff you throw into a giant data set and curate it and all the sorts of things we'll be talking about, and then tell the machine, like, okay, figure it out. What sorts of things that we as human physicians or care providers might not see are going to be able to predict sepsis in some sort of high quality way such that we can then intervene. Like that sort of prediction is bread and butter machine learning. So what does that actually look like kind of upstream? Like how do we actually do the prediction, and what sorts of things do we need to worry about when we're doing that?
So I'd like to maybe start with thinking about what happens upstream of going into these systems. Again, not because you will necessarily be interacting with the creators of these systems, although we should like to think about these systems as, being constantly in progress, going through some kind of iteration towards making better systems. But that point aside, we often get caught up around this word about bias. And I don't want to say that bias is not an issue. It's just that we're actually talking about a bunch of different issues about what is happening upstream when we're designing these systems. So for instance, when we're thinking about a sepsis prediction system, we have to make a lot of choices that are really consequential. So that might include things like what even counts as sepsis. With all sorts of different medical events, you're actually just looking for what are these sort of external or, what are these signals we can use to declare that this is the event that's happening or that is likely to happen. And so different teams have done great work trying to investigate what actually goes on behind different systems that are actually in use. Karandeep Singh's team has done great work actually looking at the EPIC sepsis prediction algorithm, looking at what are the choices going into what counts, and perhaps what is that going to be susceptible to? So I'll give a few examples of what that looks like. But these choices of what is sepsis also goes with, what are we predicting? Are we trying to predict what we want to intervene on? Is it the time to intervention? If what we're trying to predict is, say, care needs, you might be working with whatever data you have. So that might look like, okay, care needs might be well represented by past care costs. And so that might be a useful proxy. So you can start to think about how different choices about, maybe the system pays a lot of attention to this kind of input data, or examples that look like this kind of a patient, and how that might start to show up. And so where this then becomes an issue is if we're using a system to try and make a decision, that often means there's some kind of decision threshold, just as you might make a decision based on other kinds of inputs. When it gets this bad, you might want to act. You might also have some amount of uncertainty, but that may or may not be communicated particularly well. And the way that these systems are designed may not actually be what we might call externally valid, which is to say it's possible that in a rural area, or in on a different sort of set of demographics of patients, or even on a different sort of technological platform, you might have different types of inputs that would give you different answers. And as we have all felt very strongly recently, if the conditions change, for example, there's a major pandemic, and that changes both the availability of resources, but also sort of the types of symptoms, properties showing up within the, healthcare system, who's in the ER and why, that will change the performance of what these systems are. So a really important example was how some sepsis prediction algorithms really started to basically fail during the early stages of COVID, where things like the role of fever in predicting bacterial sepsis, that had been an important predictor. And given the sort of changing nature of which patients were using the healthcare system at the time, that really changed the nature of sort of who was getting flagged for sepsis intervention and what resources would be given for those patients as well. So that's, the sort of mess that we're coming from. And we end up with these systems with these really clear answers. Yes, intervene, or no, don't intervene. If we're lucky and it's an advanced system, it might say, I don't know. But even around those, we have some degree of uncertainty. And then just one last thing that, I've mentioned, there's different demographics and where these records are coming from. But if we think about, for example, systems trained with electronic health records, as we all know, electronic health records are used for multiple different purposes. So thinking about reimbursement and payment, thinking about sort of what you want to flag to insurers versus care coordination and record keeping in that sense. And how those records are used and how those are sort of built in as signals of what is actually going on with the patient. Our systems they don't have the right answer. They don't have the true answer. And we're using what different providers, different systems, what different demographics, how they all show up on these sort of multi-use documents. So that's what we're working with. And so again, our systems might get better, but we're working in a messy space. So how does the law fit into that?
The law turns out it makes it much messier.
Oh, great.
Still sticking with the upstream part of this, right? Some of the things that Abby was flagging here are, questions of generalizability and questions of whose data get included in the system and whose data don't. And the law shapes these in a pretty messy way. The two areas that I think of as being kind of most important in this space are, and this is both law and ethics, are privacy and kind of intellectual property. So on the privacy space, and this is intertwined with informed consent as well. Both of these are about, protecting private information and respecting patient autonomy. There are really serious limits on what kind of data can be used for lots of good reasons, right? Patient privacy, very important. Patient autonomy, very important. How that shakes out, though, is the fact that hospitals and health systems tend not to share data very much. It's quite hard to share data across various systems. HIPAA, the Health Insurance Portability and Accountability Act, creates limits on sharing data unless it's de-identified. And that means that it's going to be harder to generalize these insights from one place to another. It's also the case that HIPAA even restricts the use that hospitals can make of their own data, particularly in terms of saying research, generalizable research that's aimed at generalizable insights is not typically permitted on identifiable health data. On the other hand, quality improvement is. Sorry, I should put that in scare quotes. Quality improvement is. So what does this mean? This means that if I want to develop a machine learning algorithm that says, hey, which of my patients are going to get sepsis? As long as I say, all I'm interested in doing is improving the quality of care at my hospital, fine. The law says, don't worry about it. That's the kind of thing you can do. But if I want to figure out, am I actually understanding things that are universal about the condition of patients? Am I creating insights that should be shareable with other hospitals? Am I expanding our store of knowledge and making sure this isn't about idiosyncratic things at Michigan Medicine, but instead should also work in Dearborn and Flint and Iowa and Massachusetts? Well, then all of a sudden I'm not doing quality improvement anymore. Then I'm doing research. And then HIPAA says, sorry, it's not the kind of thing you can do unless you go and get informed consent for each patient and particular authorization for doing this, or jump through some other procedural hurdles. So it's not that law blocks this kind of research, but it makes it harder and it exacerbates some of the problems that Abby just mentioned. And I'll say just a little bit, privacy is on one side of the thing, intellectual property is on the other side. A lot of health systems have gotten the idea, not unreasonably, that these type of data are worth lots of money and that this is going to be their ticket to vast riches that will come from figuring out health with machine learning and AI. Turns out when you think what you have is the new oil and it's really valuable, and when you can say, oh, I definitely can't share that because I have privacy concerns and the law doesn't even let me share it and neither do ethics, then it's particularly easy to also say, it turns out it's good for me. If I keep this secret, if I keep this proprietary, I can potentially make money down the road in a way that I wouldn't if I'm just willing to share it. Not great for us in terms of figuring out how these things really work, especially as the technology is still developing. But again, just to hammer this home, these aren't problems that are going away in 5 or 10 years as the technology gets better. These are ongoing constraints in how we think about data and developing AI in health. But that's all upstream. And what happens once we've done some of this upstream work? So we're going to shift now from talking about the upstream stuff, collecting the data and figuring out what goes into the models, to once we've got a model, like how do we think about implementing it in a health system? And here, I'm just going to say one thing about the law, which is you might think that FDA would say, hey, I'm going to regulate this. And we will know, just like we know with most other medical technologies, it's got to work, right? It's got to be safe and effective. FDA deals with medical technology. I know that that drug should work because it went through FDA. I know that that device is supposed to work and it's supposed to be safe because it went through FDA. Probably true with medical AI, right? Definitely not. Not even a little bit. For a few products, they go through FDA. A few things that you get from commercial vendors, some commercial vendors, not the stuff Epic is integrating into your electronic health records already, by the way, but some standalone commercial products. All the stuff that's being developed in-house, the homegrown stuff, I have lots of faith in our fine friends and colleagues at Michigan Medicine who are developing AI for use at Michigan Medicine. But I've got to have that faith because the FDA is not involved at all, at least for those type of products. In-house products, things where a human physician is kept in the loop, who is just provided with information to make a recommendation, or that makes a recommendation and leaves the final decision to that care provider. Regulation is not a part of it. So if we might think that's how we're going to be sure this stuff works, think again, because that sort of check and quality guarantee is just not there. Abby, over to you.
All right. So if the FDA won't save us, I would say actually thinking about implementation, thinking about procurement is in one way someplace where the attendees here can have the most say in how these systems impact our lives, our healthcare systems more broadly. And And so what we might have with, for example, various committees at Michigan that are interested in procurement, adoption of different tools, what actually implementing different tools looks like in practice. Some of the main concerns that we've brought up already of, does this work well with our population? There's a lot of trust that goes into, for example, these proprietary algorithms reporting that they have, say, useful external validity. It turns out folks at Michigan, as well as other places, have done various audits on these kinds of systems to say, like, hey, are we actually doing as well as we think we are? Are we actually able to make the kinds of predictions we want about the populations that we want? So some of this kind of on the ground auditing of, do these systems do what we think they do is one way to sort of poke at, are we actually okay with implementing this kind of system? But this is where I think having some of this understanding of what happens upstream is going to be really valuable when you're making these decisions, because even if sort of these validity, accuracy, whatever precision is sort of reported as good for your system, there are a lot of ways in which that doesn't necessarily apply. There's a lot of uncertainty that isn't being communicated. And so when you're thinking about what systems you're bringing in, for example, to an operating room, you want to be thinking about not just, I'm worried about having too many tools and too many alerts, but also, will I be able to reason about what's going on? Will I be able to understand, if there's an important time to override? And we'll talk a little bit about these sort of bedside in use kinds of interactions with these systems. But you have to be able to bring in this sort of demographic context, the structural context of who developed these systems, what they knew about the system, what was, something you developed for pre-COVID time versus, a peak versus a flattened lower curve moment is going to look different. And so as we think about resource allocation and how we want to bring in these different tools, you really have to be able to consider these different populations. And so that's not to say, don't let anything in, it's too messy. That's not to say, let it all in, it's fine, just everything is bad, we'll take what we can get. But just to say that thinking about not just, not necessarily trusting what you see from systems, but also creating opportunities to have the kind of contestability and feedback from, practitioners on the ground using these tools saying, hey, these are really bad for this kind of patient, or we're getting, way too many alerts. Having these kinds of channels of communication can really help with, informing both procurement decisions as well as the development of these kinds of in-house tools. So a lot of this is thinking about what process goes behind the use of these systems. And we really think this is where the upstream through the downstream effects are really important to think about them. And so I've already indicated thinking about what's actually going on in the moment at the patient's bedside, for example, like a decision to intervene and doing that with the help of an automated system, a machine learning system. This is where we might have more experience working with systems. You might be used to getting, having serious alert fatigue of, oh yeah, that thing always goes off. We just know that that's a noisy signal. It's not actually going to be telling us something. There's a whole range of these human factors of, what kinds of information do we want to be giving, say, you, the practitioner, but also there's a lot of really important design decisions going into, for example, the visibility of ambiguity or how you might reason about how a system works. And this is sometimes more clear. Sometimes you can sort of play around with, okay, if I tweak this input, would I get a really different answer? Would I get something different? They're 59 and 364 days old. If they were 60, would they get a different outcome? You can start to think about what are these, sort of small differences that might be changing how your system is working. And actually, even just having that ability to reason about your systems, understand what they're doing, understand when you might want to override these systems is really, this is an important place where humans in the loop are still really crucial. On the positive side, this is an opportunity. You can think about how these systems are trained. You can ask, does this apply to my patient? Dorothy Roberts is a sociologist who writes a lot about corrections for race, where you might say, this score for an African-American population should be interpreted this way. Other scholars like Ziad Obermeyer have written about how populations with systematically lower access to healthcare appear to have lower healthcare costs, which can be interpreted by some systems as having lower healthcare needs. So if you have that sort of background and you can think about, okay, I don't actually trust this correction, or I might not trust what this is reporting about my patient, this becomes an opportunity to engage and override what your system is. On the other hand, this is also a great place for potential biases to come back in. So our systems themselves might be biased, but which patients we choose to intervene on and override these systems for is just yet another place for human bias to sneak back in. So what else could go on?
I love this. I love this interaction. I love this interaction of bias between recognizing that, like, the system's going to have biases, and you got to recognize that the system has biases, and try to help correct those. Whether it's upstream and thinking about how do we help developing these things, implementation in terms of what quality measures do we need to take into account, and then in the bedside when we think about, hey, this system's biased, I shouldn't believe it. But that last decision in particular, man, it's just such an easy place for the provider's own bias and implicit bias to slip back in and say, one particular type of patients, turns out the algorithm always seems to be wrong. And maybe that's because the algorithm's always wrong for one type of patient. And maybe it's because the human biases of the human in the loop just have different views from what the algorithm does. So it will surprise no one to know that I find it particularly interesting how the law thinks about this. I think the law of medical malpractice and tort liability shows up here a little bit. And the question is kind of what happens when you have an algorithm that's saying things that you don't agree with. So in our sepsis example, if the algorithm's saying intervene now, but you don't think it's right because you don't see it coming, do you intervene? Or if the algorithm's saying don't intervene now, but you think, I should intervene, is there a problem there? And I think the interesting point here, of course, is the bits where we hope to get stuff out of AI are the parts where it's not obvious what the answer is, right? If our hope is that AI will help us improve care by saying, here's something you wouldn't have spotted on your own, turns out you wouldn't have spotted it on your own, because that's kind of the point. And so there's often going to be this kind of disagreement. And medical malpractice law, frankly, is pretty conservative. It turns out, on the plus side, medical malpractice law makes it, on the plus side, for all of you folks listening, medical malpractice law makes it pretty tough to actually win a malpractice lawsuit against physicians. That's part of the small c conservative of medical malpractice law. But part of that comes from the fact that following the standard of care, which is to say what other physicians would do, is typically going to be protected conduct. Typically, there's not going to be liability for that, even if something bad happens, if it's kind of what the average physician would do in that type of situation, or the average care provider or nurse or physician's assistant would do in that type of situation, even if the algorithm tells you something different. So if the sepsis watch system says, hey, you should intervene there, and you say, I don't see it. And it turns out you should have intervened there, and the patient goes septic, like, law is not really gonna say you got that one wrong, because it's, as I said, it's pretty conservative. And if most people wouldn't intervene there and you did what most people did, that's probably okay. Now, worth noting, this is a place where things might change, and they might change pretty quickly. Because if it becomes standard of care to say, we're going to use Sepsis Watch or some other sepsis watching algorithm, then not using it, not intervening might become more problematic. It's worth noting that to some extent, this is going to be an either or situation, because like, if you would intervene on your own, you're probably going to intervene. And if the algorithm says intervene, why not play it safe and probably intervene? So it's going to shape care in a different sort of way for this type of system, in as much as it's probably just going to increase what happens at the cost of more systemic costs, more interventions, more worry about things. And we're probably going to be ignoring signals less frequently, at least for this type of yes, no go algorithm. One last area of law, though, that I wanted to mention is the question of informed consent, which frankly, it's law and ethics. I don't think there's a great answer here. Right? The question is, if you're using an AI system that you don't understand, maybe that no one fully understands, to help guide care, if you're intervening just because the algorithm says, hey, give them vasopressors now, they need it right now, right? Do you have an obligation to tell your patient that that's what you're doing and that's why you're intervening, because the algorithm told you, yeah, it's a good idea, and it's not quite sure why, and you're not quite sure why, but it's been right a lot of times in the past? That, frankly, I think is still an open ethical question. I think from the legal point of view, it's probably not your legal duty to provide that information at this point in time. Informed consent also pretty weak doctrine in terms of the law actually finding liability for people not sharing information, especially when it's an edge case like that. If you're curious, Glenn Cohen at Harvard has a giant 60-page piece going through this in lots of detail that came out in 2020. So if you want to read lots about that, that's the place to go. But this is also, I think, a place where here's a new tool. How do we need to share the use of that tool with patients is an area where both law and ethics are still figuring out exactly how they're going to treat this sort of development. But one of the things that I just mentioned was this is kind of an A-B system. Do you intervene? Or this is kind of a go, no-go system. Do you intervene? Do you not intervene? Hey, what's more and more IV? Like, is that really a problem? But not all AI is going to be like that. So Abby, how does it change once we shift over to like different types of AI systems?
That's a great question. So, right, we've been talking about this yes-no intervention, potentially yes-no, I don't know, as the advanced version. But increasingly, we're also seeing systems where we might have possibly different treatment arms. We might think about, different treatment regimes, different levels of prescription, different types of clinical decisions that you would see playing out. And so there you might have qualitatively different options, or, something by a matter of degree of how intense some need is, for example. And this can in some ways mask some of the issues that we saw earlier, because maybe this gives us more nuance. Maybe this lets us actually treat different subpopulations differently. So actually we're able to capture, this demographic, because of the data that we have, they look different. Whether or not they actually are different is not what I said, but what they look like from the data. And so this just means, though, that the problems are shifted to possibly they're hidden. There's a nice analogy, actually, to thinking about just with evidence-based medicine. If you're thinking about which populations you're learning on and which populations get, treated with different types of treatments. And so there you have the same kind of thing. Of course, who we have seen this evidence on is going to be a major sort of source of insight into how well we expect something to work. But we also obscure some of these decisions, again, about sort of how we might choose to do these treatments. So I really want to say that, these kinds of questions you can ask your system, again, is the 59 and 364-day-old really going to be so different one day later? Or is, actually a, built-in tag for race or sex, when those are actually built into your system and part of your prediction system, there's a lot that you don't get to see. And so really sort of being able to think about what went into the system, sort of what choices were made, what you can expect from it. These issues are all still here. And I'd argue that sort of just like everywhere else in medicine, and other settings, there aren't necessarily right answers, but it's really just our ability to reason about the systems we're working with and understand sort of why we are where we are. So that all said, I don't want to sound all negative. This is a really exciting, meaningful area. Better treatment, better allocation of resources, more health. These are really great directions. Improving the quality of systems, actually getting data for different populations without overextending the surveillance of different populations. These are all really, meaningful directions to be moving forward with. But we just want to highlight that there's a lot going on behind the scenes and around the use of these systems and the interpretation of these systems. And so we think it's just really important to understand this context so you can think about this sort of broader picture, this broader multidisciplinary problem of how we can actually intervene on health.
Yeah, I completely agree. And the one last point I'll add is these are complex issues to be aware of and complex issues to think about. And I wish that I could tell you, don't worry about it. Just wait a decade or 5 years or 2 years, and you won't have to worry about these issues. And I wish I could tell you that, and I totally can't. I hope the law gets better. I hope ethics figures out answers to some or ways to make these questions easier to ask and easier to think about. But even as the law improves, even as ethics wrestles with these things more, even as the technology matures, there are still going to be deeply embedded judgments about whose data gets used, how it gets used, what systems get implemented, what thresholds and what judgments end up getting made, and how that shows up on the monitor next to the patient. These issues aren't going away. And so starting to think about how best to engage and grapple with them now is, I think, the way we got to go and the way we got to keep going. So I think that's it for us for talking at you. And now we're really excited to talk to you. And so really thrilled to take your questions.
Great, thank you so much. That was wonderful and scary at the same time, because as someone who watches a lot of sci-fi, it's always the AI systems that end up taking over, right, and running the world. And so I'm seeing there's a couple questions here that have a theme along that, and it's one that I kind of thought of as well. As a novice in this area, complete novice in this area, thinking about how systems are trained, and often we're in a healthcare system and we don't really have, control over these algorithms. So, I think sessions like this are really important to help people understand what's kind of happening in the background and kind of where we are. But there was one question here that I love that says, do these systems typically allow the practitioner to plug in some close hypothetical alternatives to test how robust a system recommendation is?
So I definitely was implying that in some systems you can do this. That's not always true. And so, for example, and sometimes this is partly related to what visibility or transparency you have into what the inputs are to these, or even into the interpretation of the results. So one place where this shows up, there's a short little piece by Dorothy Roberts, who I mentioned, about getting rid of race corrections, because that ends up being sort of something that's intended to sort of increase equity, but actually has some sort of downstream negative effects. But not all systems let you test by, what if it happens if I uncheck that box, or I, play around with their age. So when you can do that, great. When you can't, this is where having that, actually just having those like lines of communication around, what are your colleagues' experiences? What are your, colleagues at different hospitals' experiences? How do those vary with this kind of system? That kind of actually sort of folk knowledge ends up being crucial to being able to understand what's going on. And it's a different kind of, I guess, vigilance to thinking about these systems, but in the same way that you're sort of paying attention to environmental conditions, this is also just another type of input that you can reason about. And it's just, I think, worthwhile to remember that it's not just a pure objective outcome.
Yeah, I think it's also worth thinking about the relationship. Like, part of what we've emphasized here is upstream versus downstream, and like where we think about reasonable inputs. So like one possibility is you think, hey, I'm going to be a provider or someone at the bedside, and I'm going to play around with this and see whether or not I trust this particular recommendation. Does it change if I switch the patient's age by a day? That's one way of thinking about how to make sure these systems are getting it right. But like, wow, is that a lot of time and effort in terms of people actually doing this? And I'm not working in a hospital, but I have the sense that a lot of people are fairly busy these days. And so not just these days, forever, all the time. And so one question is kind of, as we're thinking about these systems, as you're thinking about implementation, like how can you take that sort of information and that sort of interaction and move it higher upstream so that you don't have to have people at the bedside trying to figure this out every time, because they often just don't have the time.
And knowing which of those levers you can push and, which levers are available themselves. I totally agree. And so, yes, and I think this is partly why I think all of these upstream decisions are so important, because so many of these choices are going to have been just not visible. So, if this was all trained on urban high resource hospitals, that might work, those systems might work really well in those settings. But you may not even know that that's sort of what they're trained on or what they're based on. And, California might look different than Idaho, than Michigan, and, variation within Michigan. We know we have these kinds of variation that's going to be built into all of our systems.
So as a follow-up to that, there's kind of two questions that I think are asking very similar sorts of questions, more around kind of the legal implications for kind of interpreting the data versus having these black box models, and kind of, do you foresee that the law might potentially be moving away from a more conservative standard of care to siding with some of the AI if somebody goes against it or ignores it?
Yeah, so I don't think we're there yet. I think it will be hard once we have more systems being implemented and better data about how well things perform. Like, it's going to be hard if we have a situation when at some point in time down the road, we can say, look, the vast majority of physicians get this right 90% of the time. This system gets it right 98% of the time. It's going to be hard to say, that's not what you should be doing. But I should also say, there's a huge difference between what you should be doing and what the law says you have to do, otherwise you're being negligent and committing malpractice. And it is frankly a low bar of what counts as not malpractice. There are doctrines about respectable minorities and two schools of thought and honest errors in medical judgment. And there are just a bunch of ways that the law, tort law, at least medical malpractice law, says, look, if you're doing something the old way, that's probably fine. So is it possible that we'll get a change to the standard of care that says you should do it this way? Definitely. Is it possible that in the near term, we'll get a shift that says the standard of care is you should do it this way, and if you're not using the algorithm and following the algorithm, you're falling below the standard of care? That strikes me as a lot less likely in the near term. Which is not to say people shouldn't do it and that we shouldn't have practice organizations, or hey, maybe liability insurance and medical malpractice liability insurance might say an important thing to do is be up to date on how AI systems can help your care. That's all possible. The likelihood of getting sued for not doing what an algorithm tells you and instead doing what you were trained to do and then winning, that strikes me as pretty low for a while. Although again, I'm not your lawyer.
I'm gonna move on to couple other questions that are also, I think, interrelated. We had them come through. The first one is about privacy laws impacting the machine learning models. And it says, as we've seen in computer vision, there can be artifacts of training data that wind up within the model. How does this type of ghosting lead to problems? And using models trained in one clinical setting versus another. And I think this has to do with how do radiology ML systems handle it, since they're using clinical data for training. And then the other question has to do with, are there resources available that that are large data sets de-identified where you could use them for the development of models, and does HIPAA prevent that from happening?
There's a bunch of things going on here, and there's a bunch of stuff to talk about. I think mentioning the artifacts that show up, I think, is a really just sort of the weird things in data that can get learned, right? So computers, machine learning, it's not that intelligent, right? So if there's a signal, it will learn the signal. if, older, lower resolution imaging systems are more present in areas that have a really high frequency of, this kind of medical outcome, as opposed to areas with higher resolution, newer systems, a really good signal to pay attention to if you're, a computer looking at these like sets of images would be, how good quality is the image, or even, oh, it still has the flag of where this data was taken from. This ends up in these systems. And it's really, it's hard to debug. Some of this is, technological improvements with, both what data is had and what kinds of explainability or interpretability kinds of tools are available, but we're not going to catch them all. And so I think this is partly where I think, not to harp on this, but I think having just kind of like the types of critical thinking here in terms of, what's upstream, what do we have right now, we can trust this, but we also have to know that, just in the same way that I might have accidentally sort of overweighted this kind of signal that I saw myself, the computer can do that too. And so, and in really sometimes sort of surprising ways. So I think that's a really good point. There are some increasingly more data sets that are available under various sharing agreements for different purposes. A lot of something that also happens upstream with imaging data is that often you have sort of human hand-coded, labels of whether that's experts saying this is evidence of this kind of outcome, or even just literally you hired a bunch of teenagers to say like, yes, that is a real boundary on this image, and no, that's not, that's a piece of dust, and that's actually a meaningful signal. So, you have a range of these kinds of inputs that you're learning from. And so, so this is an ongoing conversation. So that's sort of a non-answer, but there's so much.
Yeah, I'm going to say two quick things in response. The first is you missed my favorite story about machines learning on weird stuff. It's not the wolf in the snow story, although that's a good one. It's a medical story, and it turns out, so they trained a machine learning algorithm in, and I can't remember the names of the hospitals, but they trained it in a New York hospital to identify tuberculosis from chest x-rays. Turns out, useful thing to be able to do. It was really good. Just did a great job predicting. Then they tested it in another hospital, and it did a really bad job. And they're trying to figure out, what is it? Like, why did it fail? Like, these are just chest x-rays for TB. Like, you should be able to figure this out. Well, it turns out what the machine learning algorithm actually really focused on was whether or not the x-ray machine was portable or fixed. And it turns out when you got really sick patients that don't leave the bed very much, you bring the x-ray to them. And so the algorithm that's what it focused on. But that's not the thing we care about, obviously, right? It's not focusing on something in the image. It's focused on what kind of machine took the image. So that's always a concern. And part of the reason that I think it's so important to be able to do these things where you assemble data from different places, which addresses kind of the second half of the question about big data sets. So the question said, anonymized big data sets. Honestly, privacy law doesn't say a lot about that. Once you anonymize things, despite the fact that anonymization doesn't work and we can re-identify things, and it's deeply silly to imagine that it's important, we'll set all that aside. Do whatever you want with it. The law doesn't really care. So big anonymized data sets, yeah, Mimic's a big one out of Boston. I would be remiss if I didn't point out our very own Michigan Genomics Initiative big data set, which is exciting. And in fact, not only has lots of interesting data, but has a full, robust patient consent process for secondary use of data. Although, fun fact that we didn't get a chance to mention in the talk, when you have really robust informed consent procedures because you're trying to do such a good job of respecting patient autonomy that you're really making sure that everybody's okay with their data being used for this type of work, turns out different people say yes and say no. And so you actually bias your data set and you get a non-reflective data set out of it unless you're really careful. If you're curious, it turns out I'm on a team that just published a paper on this particular issue for a Michigan data set for MGI. And so I've dropped that into the chat. So there are lots of resources out there. MGI is an awesome one. Their consent is awesome, and they're working on the diversity issue as well. But it's really hard to get right. And as I said, the law doesn't make it a ton easier.
And I just want to quickly underscore one of those points about how if you do release these data sets, even if you do have certain kinds of demographic data, just in the same way that assistants might learn, is this a fixed X-ray machine or a mobile one? You can appear to learn patterns from these data sets of like, look, there's a demographic difference. The data suggests that the X-rays on this kind of patient tend to look this kind of way. So maybe this tells me something about those demographic groups. What you are actually finding is, again, just from these upstream patterns, who is ending up in these geographical areas being analyzed by these different tools. And so there's something just really slippery happening with how you interpret and how you think about what's going on in these kinds of vision systems. So that's just an extra plug from something I'm working on.
We have a couple more questions that have come in. So given the FDA's current non-role in regulating machine learning, what do you see as the ideal way to ensure the safety and efficacy of these products? And what is their potential for fraud or abuse by doctors or management?
Oh, that's such a hard question. I wish I had a good answer. It's so hard to make sure that this stuff is done right, especially given how context specific a lot of stuff is, at least now when we're working kind of at in-house data sets. It's really tough. I think in-house governance structures by places that have the resources to do it are going to help, but I don't have a good answer. I wish I did. I think, for instance, like, I fully believe that the folks here at Michigan Medicine who do things like look at how an algorithm performs and how it works at Michigan and run it in the background silently to make sure, yeah, it's working well, and then keep checking on it over and over and make sure it's working well. I think they're doing it right, but that's hard. And that's hard to do if you're not someplace with a lot of resources and a lot of scientists focused on it. My best bet is more transparency, data sharing kind of performance metrics, opening this up towards other people being able to probe this. But as I said, law doesn't make that especially easy either.
Let's see, I think we have time for one more question, and there was one that came in early, and I'm not sure we're going to be able to answer this appropriately, but I just wanted to ask. This is an individual that's interested in improving the clinical care for individuals in the correctional system. Very challenging population to work with. So how do you recommend those entering precision health? How do you recommend for those entering precision health that are interested in improving outcomes for communities that are socially stigmatized and funding opportunities are sparse? So do you have any recommendations for someone who's kind of looking at marginalized or socially stigmatized populations?
Well, I wish I had good answers. It's super duper hard, especially since the law says, these are vulnerable populations. So we're going to put extra research safeguards in, which makes total sense, but makes it really hard to say, like, here's how we actually improve the health aspects. But Abby, it looked like you were gonna jump in.
Yeah, I just want to, again, this is a totally insufficient answer, but that community-centered approaches are really, really important in these kinds of settings. Again, healthcare records are dumb, computers are dumb. We're just working with what we have. And this is where I think a lot of sort of context and understanding what interventions are meaningful, what signals are meaningful, who is ending up in these systems for what reasons, I think this is just something where I think having really sort of community-centered approaches and thinking about what outcomes you're actually trying to intervene on and why, I think can be just the most valuable way to think about working with these kinds of communities.
Great, thank you both so much. I'm very apologetic to the people whose questions we were not able to get to. They're very interesting questions. But I want to thank everyone for attending. You will be receiving a survey shortly after this, which will also include a link to the recording of this, as well as information about our symposium that's happening in March. And so we would like to encourage you to register early. It will be an in-person symposium, but we're also working to have a remote option as well. However, we have an excellent speaker. Dr. Bob Wachter is going to be our keynote speaker. And so again, thank you, Nicholson. Thank you, Abigail. And thank you, everyone, for attending today.
Thanks, everybody.
Thank you.
Bye.
Bye-bye.